everyone. I hope you're all doing well. I'm Abdurrafeh Farooq from Study Project UHS and a second year DMC student. Today, it's our pleasure to host today's CBC interpretation session, and we're delighted to have Dr. Saqib Hussain Ansari join us. We are grateful for his expertise and time. Dr. Saqib is a renowned consultant, pediatric hematologist, and bone marrow transplant physician. He is the CEO of Children's Hospital Karachi, a state-of-the-art 50-bed hospital specialized to provide comprehensive patient care and standardized treatment to its patients. Dr. Saqib is also the president of Omair Sana Foundation, an esteemed NGO registered in both Pakistan and USA, which has a two-pronged mission of working for the treatment and prevention of thalassemia and providing emergency relief in natural and man-made disasters. We are immensely grateful to Dr. Saqib Ansari for giving us his time out of his extensively busy schedule. Without any further ado, I would like to invite Dr. Saqib Ansari to begin with the workshop. Guys, please wait just 2 minutes. The host is starting soon. Dr. Saqib, are you there?
जी अस्सलाम वालेकुम।
Walaikum Assalam. Dr. Saqib Hussain Ansari, you may start the session.
Okay, so I'm audible. आप लोग मुझे सुन रहे हैं?
Yes, sir, सुन सकते हैं.
Okay, so Bismillahirrahmanirrahim. Like fever के बुखार जो है, it's not a disease, it's a symptom. If someone is having fever, you are not going to treat the fever, you are going to treat the reason of fever. While the patient is having fever, you will investigate the patient for malaria, typhoid, dengue, whatever. In the same way, if someone is having anemia, you are not going to treat the anemia like just giving the blood or treating with some multivitamins. You are going to find out the cause and the reason. I want to keep this meeting up some what like discussion and two way. So मैं अकेला लेक्चर देके चला जाऊं, वो तो आप इंटरनेट से कोई भी लेक्चर सुन सकते हैं, मगर थोड़ा सा कोई एक दो बच्चे वॉलंटियर करें और प्लीज़ मेरी सवालों का, मेरी बातों का आगे से जवाब भी दें ताकि मुझे थोड़ा सा इंटरेक्टिव रहे ये. ठीक हो गया जी. सो आपके ख्याल में मोस्ट कॉमन कॉज क्या होता है एनीमिया का?
Fatigue,
Say again.
blood loss,
Okay. Anyone else?
iron deficiency,
ठीक हो गया. और कोई? ठीक है, चलें इसको यूं ही ले लेते हैं. सो न्यूट्रिशनल बोलें तो ज़्यादा अच्छा होगा. सो न्यूट्रिशनल एनीमिया इज़ द मोस्ट कॉमन कॉज ऑफ एनीमिया वर्ल्ड वाइड. ओके, कुछ केसेस हैं ताकि हम थोड़ी नॉलेज अपने अंडरस्टैंडिंग कर लें कि हम इस पढ़ाई, इस लेक्चर या इस टॉक के पहले हमारी क्या अंडरस्टैंडिंग थी और फिर बाद में हम देखेंगे.
Can you please speak in English? Can you speak in English?
Okay, you know what? I used to teach in a language where I see my dreams, and it's always most of the candidates. So I will keep it a mixed form of English and Urdu, both, because that is a problem. Our people should learn by heart and they should understand. Okay, let's see. If some 16 years old girl complains of weakness, lethargy, dietary history poor, want to look smart, normal bleeding history, no history of GI blood loss. So her hemoglobin is 6, MCV is 52, MCSC 17, RDW 21, RBC count 5.4, white cell TLC, total leukocyte count 5.2, and platelet count is 215. Any input what this may be?
microcytic anemia,
Very good, microcytic anemia. So we are dealing with a nutritional anemia, and as per the history, dietary history is poor. If dietary history is poor, the patient is not taking proper food, and nutritionally patient is compromised, and that's why we did not find any other blood loss like menstrual blood loss, like GI blood loss. So most likely there's a nutritional deficiency, and there's a medical condition when young girls want to look smart. What is that medical condition?
anorexia,
Anorexia nervosum. So they harm themselves. 25 years old boy, recurrent diarrhea, weight loss. On examination, height and weight are not appropriate for age. No visceromegaly. Hemoglobin is 7.8, MCV 1 in 10, RDW 14, white cell count 8.4, platelet 170. Any gut feeling what we are dealing with?
macrocytic anemia,
Macrocytic anemia. What may be the cause of macrocytic anemia as per the history? So the most common causes of macrocytic anemia is B12 and folate deficiency. And nutritionally, this child is compromised, and height and weight is not as per age. So um, recurrent diarrhea की history है. Any idea what it can be if someone is having recurrent diarrhea and height and weight is not appropriate for age? What it could be? Can anyone tell me who is from first year and second year MBBS? If someone is from first year and second year MBBS, just let me know. So I should understand what's the level of knowledge and academics you people have. If no one is from first year and second year,
First year.
okay, first year, good. So I do not expect a lot from first year and second year, but I do expect something from third year, fourth year, and final year. What is the most common cause of recurrent diarrhea? So inherited condition associated with recurrent diarrhea is one of the most common cause after infections and parasitic infections. The most common inherited condition is celiac disease. If examined recurrent diarrhea, not appropriate height and weight, hemoglobin less, MCV high, so you should get in your mind that are we dealing with celiac deficiency. So it is important to remember that anemia is a clinical sign, not a single disease by itself. Need to look into the underlying cause of the disease. Either we are dealing with celiac disease, either it's an energy nervosum, either it's a blood loss, either it's a nutritional deficiency, or we are dealing with the anemia of chronic disorders, tuberculosis, infections. So you have to find out the cause, or thalassemia, red cell membrane disorder. Bleeding disorder like von Willebrand disease in girls, which is associated with menorrhagia. So if you are not treating menorrhagia, you are not treating bleeding disorder, you're just giving blood. So this is not a sensible approach. A physician, a hematologist, a basic physician working in a community physician should approach the patient by the proper appropriate diagnosis and the cause of the disease. So hemoglobin of less than 11 is anemia, and in men, a hemoglobin of less than 13 is anemia. You got it? So in a women, if hemoglobin is less than, thank you sir, less than 11, it's anemia, and if it is less than 13, we are dealing with anemia. So मेरे पास जब patient आता है, when patient come to my clinic, I saw his CBC. So if there's hemoglobin is less, like 7 or 8 is hemoglobin, or 6 hemoglobin or 5 hemoglobin, what next I will do, I will check what's the status of platelet and white cell count. If platelet and white cells are normal and only hemoglobin is less, so I'm dealing with isolated anemia, not the bone marrow failure syndrome, not a condition associated with bone marrow destruction or bone marrow involvement with leukemia, lymphoma, cancers involving marrow. If there's isolated anemia, most likely I'm dealing with any condition, any cause of disease which is associated with isolated anemia. Okay? But if a patient came to me with a hemoglobin of very severe anemia, very severe thrombocytopenia, very severe leukopenia, then it will raises my concern. Okay, is it really only anemia, or I'm dealing with a condition like aplastic anemia? I'm dealing with a condition like Fanconi's anemia, when the bone marrow is failed and bone marrow is not producing either red cells, not white cells, not the platelets. So I have to identify, am I dealing with isolated anemia or not? So when you saw a CBC, when a CBC came in, hemoglobin, the next thing you will see is platelet and white cell. And if you are dealing with isolated anemia, what next you will do? We will discuss this in the next slide. But at this moment, if you are dealing with isolated anemia, then what may be the cause of anemia? Is it the production defect? The bone marrow is not producing red cells, or it's the red cells breaking down? The bone marrow is producing red cells, but red cells are destroying when they came in your peripheral blood, or there's a loss of blood through gastrointestinal tract, through menorrhagia, through vomiting, or through any other cause. So when I'm dealing with a CBC, with a patient presented to me with isolated anemia, what I'm going to see, what I'm going to check myself is either I'm dealing with a production defect or destruction of red cells, or loss of red cells. ये रिकॉर्ड कर सकते हैं आप यहाँ से, तो कर दे रिकॉर्डिंग. Just give me a pause. My colleague is going to just make a recording on. Thank you. अच्छा डब्बू चल रहा है मेरे अपने काम इंटरनेट पे, वेबसाइट पे जाने के लिए. Percent you are just let me know if organizers are already recording this lecture. Please confirm me.
Yes, sir.
Otherwise, I'm going to. You're already recording, then you can share with me you're recorded. Okay, no problem. Then I'm not recording. Okay.
All right.
Okay. के पास एक्सेस आ रहा है. भाई ये बंद कर दीजिए, आपकी आवाज आ रही है, साउंड आ रही है. Thank you. So once you got a report of CBC in your hand, you are going to see, is it a production defect that bone marrow is failed to produce red cells isolated, or it's the red cells lysis, or it's a loss. Let's say production defect, hyperproliferation. This may be nutritional because patient is not having B12, folate or iron, so he is not producing red cells. Or this may be a congenital inherited conditions called Diamond-Blackfan anemia, pure red cell aplasia, where bone marrow is not able to produce red cells. Conditions, this may be inherited or this may be acquired. And sometimes in the conditions like Fanconi's anemia, where the first line which is affected is red cells, patient first presented to you with only anemia, but later in the life, after the age of 9 years or 10 years or 11 years, the patient will also develop thrombocytopenia and leukopenia. And finally, patient will develop pancytopenia, total bone marrow failure, but the first presentation may be isolated anemia. So if you are seeing a patient with isolated anemia, first thing which you want to exclude, is it a production defect or it's something else? What's something else? The second thing which I will observe and I will check and I will identify and I will diagnose and how I will apply anemic man or women is it the red cells is producing from the bone marrow, but there is a hemolysis, the red cells are marrow, and the test to check differentiate between the production, is it the production failure, red cells are not producing, or these are the red cells which are lysing, is reticulocyte count. The test name is reticulocyte count. Reticulocytes are the are the immature red cells which are circulating in the peripheral blood, and they are produced from the marrow and they circulate in the peripheral blood. So if patient's retic count is less than 2%, 1 to 2%, it is normal, but something less than 0.5% is abnormal. And if someone is having retic count of less than 0.5, this shows a hypoproliferation. It means bone marrow is not producing red cells. But if someone's retic count is more than 2% or 3%, it means that he's producing, but red cells are lying in the peripheral blood. When the red cells comes, normal red cells comes in the peripheral blood, they circulate in the peripheral blood, they are hemolyzed in the peripheral blood. So this is called the hemolytic anemia. So this is the second type of anemia, and that's how we approach the anemia, the diagnosis of anemia, and advise the patient to treat it. The third cause of anemia is hematocrit. So after a detailed history and clinical examination, we have a history of blood loss from gastrointestinal tract. Usually, the patients of adult age examination may lead to GI blood loss, per rectal blood loss, and you have to take a detailed history and examination. If, as per examination, patient is having ulceration in the anal region, or as per the history, the girl is giving history of menorrhagia, the child or adult are giving blood loss from gastrointestinal tract. Today, I have patient with large blood loss, gastrointestinal blood loss. Today, I have a lady with 50 years of the age, at almost 49, 48 years, and she is on the age of uh, um, what she said, that I have a huge blood loss and now her hemoglobin is 5, and she's almost collapsed, and she's in my daycare and she's receiving pancreatic. So you have to take a detailed history to find out is there is blood loss. You also have to understand the difference between acute blood loss and chronic blood loss. The patient with acute blood loss presented with high heart rate, hypotension, respiratory distress, and they are sick. Whereas the chronic blood loss patients, even at the hemoglobin of 4 and 5, they are doing their normal routine life and do not feel that they are sick. So this is another important point which you should understand. This is an algorithm approach my patient through this. If any anemia patient presented to me with isolated anemia, the first test I will perform is reticulocyte count. Retic count of less than 2% shows bone marrow failure or anemia due to iron deficiency, microcytic anemia, or anemia due to B12 and folate deficiency, macrocytic anemia. Okay? And if someone is having anemia and reticulocyte count is more than 2%, so it means we are dealing with hemolytic anemia. Blood is, red cells are producing from the bone marrow, but they are destroying in peripheral. So if they are destroying in peripheral, there may be two causes. Either this is immune hemolytic anemia, that is the antibodies are formed against the red cells, which are destroying the red cells. It is called immune hemolytic anemia. And if that is Coombs test. If Coombs test is positive, that is, it means that the test which is performed to identify the antibodies in your plasma, in your serum, is called Coombs test or direct antiglobulin test. If Coombs test is positive, you are dealing with, and retic count is high, you are dealing with immune hemolytic anemia. Is it clear? Someone volunteer if clear. If not, then we can stop here and discuss in detail.
Sir, somebody is asking, what was the test that you mentioned?
Coombs test, direct antiglobulin test, Coombs test. COMB apostrophe S, Coombs test, direct antiglobulin test.
The rest is clear, sir. I think
Yeah,
we
I will
mentioned all.
repeat here. Let's repeat it. I'm in my clinic. I'm on bedside. I'm on ward round. I'm seeing a report of my very dear and near. And if I saw that hemoglobin is 6 and white cells and platelets are normal, my next approach will be the first thing which I'm clear that I'm dealing with isolated anemia. Okay? If I'm dealing with isolated anemia, white cell and platelets are normal, my first test after that will be reticulocyte count. Reticulocytes are the immature red cells which are circulating in the blood. So, if retic count is more than 2%, I'm dealing with hemolytic anemia, means red cells are producing from the bone marrow and they are hemolyzing in the peripheral blood. So, that will be the first test after anemia, the retic count. And if retic count is positive, the third test will be DAT, that is direct antiglobulin test, which is also called Coombs test. If Coombs test is positive, as you can see here, it is immune hemolytic anemia, like antibodies are formed in the blood and they are hemolyzing the red cells. If Coombs tests are negative, then we will find out the causes of anemia. In a pediatric age group, I will see for the congenital causes, and in the adult age group or pediatric age group, if there is no congenital cause, in adult age group, I will find out the acquired causes of hemolytic anemia, acquired conditions which are associated with red cells which are producing or hemolyzing in the peripheral blood. Step 1, if you see the CBC, isolated anemia. Number 2, retic count. If retic count is more than 2%, the third test is Coombs test to find out it is immune hemolytic or non-immune hemolytic. If Coombs test is positive, it is immune hemolytic, diagnosis is confirmed, you will find out it's a cold immune or warm immune and you will treat as immune hemolytic anemia. If Coombs test is negative, this is non-immune hemolytic anemia, then you will find out the congenital inherited causes or acquired causes. So when we came in congenital inherited causes of anemia, if you are dealing with a teenage or pediatric age group, if a child, a baby presented to you in your clinic with hemoglobin of 6, I'm definitely going to examine the patient, and if patient is having hepatosplenomegaly, hemoglobin is 6, white cells and platelets are normal, my strong suspicion will be either I'm dealing with a red cell membrane disorder, or I'm dealing with a red cell membrane disorder, any का notice, or I'm dealing with a or I'm dealing with a enzymopathy, or I'm dealing with a hemoglobinopathy. If liver spleen is palpable, most common cause in Pakistan is thalassemia, which is a hemoglobinopathy, like red cells, beta globin, alpha globin chain. Most likely, beta globin chain is not working, and that leads to anemia, and liver and spleen are enlarged. So this is called hemoglobinopathy. And in a very early age, patient may present in 1 or 2 months of age or 5 months of age with red cell membrane disorder, which is called hereditary spherocytosis, eleptocytosis, anisopoikilocytosis. These are the red cell membrane disorders. And the third cause is enzymopathies, like G6PD deficiency or pyruvate kinase deficiency. So these are the most common inherited causes of hemolytic anemia, whereas the acquired causes of hemolytic anemia are infections, like in malaria, there is hemolysis. Microangiopathic hemolytic anemias, DIC, sepsis, when there is red cells, sepsis, DIC infection leads to red cell hemolysis, and you will find out the patient is anemic and thrombocytopenia, whereas that Coombs test is negative, so you will be more in suspicion of anemia and sepsis. So here we deal on the right side of the graph, that is that positive is immune hemolytic anemia more than 2%, retic count is hemolytic anemia, that negative is non-immune. If non-immune, you will find out the congenital causes, red cell membrane disorders, hemoglobinopathies, red cell enzyme disorders, and acquired causes are infections and microangiopathic anemia. If you go on the left side of the sheet, if retic count is less than 2%, you will either dealing with a bone marrow failure syndrome, congenital inherited causes like Diamond-Blackfan anemia, pure red cell aplasia, bone marrow is not functioning and initially red cells are compromised, or the production defect, which includes the deficiency of muscular volume of more than 100 is macrocytic anemia, and cause of macrocytic anemia, most common cause of macrocytic anemia is less than 80. You are dealing with iron deficiency anemia. So the most common cause of MCV of macrocytic anemia is iron deficiency anemia. To elaborate more on this subject, I'm going to share with you anemia in Pakistan is microcytic anemia, and in the whole world, the whole knowledge of the world, anemia. Three causes are very, very rare, and I do not want you to even remember those three causes. And two causes are common, and I want you to remember those two causes of microcytic anemia. The first one is iron deficiency anemia, and the second is thalassemia minor. So any CBC in your hand showing anemia, you will see the MCV. If MCV is less than 80, there is 98% chance you are dealing with two conditions, one of the two conditions or both conditions, that is iron deficiency anemia or thalassemia minor. So remember for rest of your life, the two most common causes of microcytic anemia, that is MCV less than 80, is iron deficiency anemia and thalassemia minor. And the two most common causes of macrocytic anemia, MCV more than 100, is B12 deficiency and folate deficiency. As per literature, anemia associated with normocytic, like MCV of between 80 and 100, is either mixed deficiency, like the patient is having B12, folate, and iron deficiency both, or anemia of chronic disorders like tuberculosis or infections, which leads to anemia. So this was the most relevant flowchart which I want to share with you people, and this gives you the whole orientation of anemia, causes of anemia. I'm quickly going to repeat it, and I want someone to please. I'm trying so hard. I'm trying so hard that you people should understand the anemia and CBC interpretation. That please someone should show his concept knowledge and repeat what I said. What I'm going to say, that if someone presented you with isolated anemia, you will check the reticulocyte count. If reticulocyte count is more than 2%, you are dealing with hemolytic anemia. There are two reasons of hemolytic anemia: immune hemolytic anemia, non-immune hemolytic anemia. You perform a test called Coombs test or direct antiglobulin test. If Coombs test is negative, you are dealing with non-immune hemolytic anemia. If Coombs test is positive, you are dealing with hemolytic anemia. If Coombs test direct antiglobulin test is negative, you are dealing with a non-immune hemolytic anemia. The causes of non-immune hemolytic anemia are congenital or acquired. The congenital are red cell membrane disorder like hereditary spherocytosis, elliptocytosis, hemoglobinopathy like thalassemia, sickle cell disease, enzyme defects like G6PD deficiency or pivot kinase deficiency. If there is no inherited cause or the age is, the patient is elderly, like 50 or 60 years, there's less likely congenital or inherited cause showed in by the later age. So there is more chances infections, malaria, microangiopathic hemolytic anemia. And then on the left side of the sheet, if patient presented to you with isolated anemia, but retic count is less than 2%, and you will have two differentiations. Either I'm dealing with a bone marrow failure, like you may have to go check the bone marrow, but not initially, not immediately. First, you will see either this anemia is microcytic or macrocytic. 99% of the causes of microcytic anemia is iron deficiency and thalassemia minor. And most of the cases of macrocytic is B12 and folate deficiency. I will share with you the three other causes of microcytic anemia, that is lead poisoning, sideroblastic anemia, and anemia of chronic disorder. In my 25 years experience, I have never seen a patient with lead poisoning, because we are not using the those equipments, those utensils which where lead was used. Lead is not in use in our community. I have seen just 10 or 20 patients with sideroblastic anemia, An anemia of chronic disorder speak of anemia which is for 6 months or a year. So these three causes of microcytic anemia are so rare that I do not want you to remember even these three causes. The two main causes of microcytic anemia is iron deficiency anemia or thalassemia minor, whereas the macrocytic anemia is B12 and folate deficiency. I want out of these 100 bright, smart, handsome, and the most shining students and the most smartest student not in Pakistan but on earth to please someone volunteer and show me that I am working so hard and I'm getting something out of it. Please, want to volunteer.
Guys, if any of you has a question, you may ask Dr. Saqib Ansari.
Not only question, if someone can just let me know, Dr. Saab, what I understand, what you said, that if I'm dealing with anemia, the first test I'm performed will retic count. If retic count is more than 2%, I'm dealing with hemolytic anemia. And then I will check for the immune hemolysis. Please, go ahead.
Sir,
Yes, boss.
sir, usually in CBC the retic count is not given, so we should always do a retic count along with CBC.
Very good question. No, what I said that when patient presented to me first, most likely I have the report of CBC which is showing only anemia. The first test I will perform after finding out anemia is retic count. So retic count after getting anemia, the let's see the CBC is the first laboratory test which shows anemia. The second test will be retic count and the third test will be direct antiglobulin test or Coombs test.
सर
Sir, okay.
Yes.
सर एक्चुअली मैंने एक केस पढ़ा जहाँ पे आरबीसी का काउंट भी कम था और माइक्रोसिटिक हाइपोक्रोमिक एनीमिया था, तो इट्स गोज टुवर्ड्स द आयरन डिफिशिएंसी एनीमिया। ठीक है, एंड देन एक और केस था जहाँ पे हाइपोक्रोमिक और माइक्रोसिटिक एनीमिया तो था लेकिन आरबीसीज का काउंट नॉर्मल था। तो यहाँ पे जो सजेशन दी हुई थी वो एचबी इलेक्ट्रोफोरियोसिस की दी हुई थी माइनर थैलेसीमिया चेक करने के लिए, लेकिन जब वो नेगेटिव आया तो यही हाइपोक्रोमिक माइक्रोसिटिक एनीमिया आयरन डिफिशिएंसी को डोनेट कर रहा है, तो ये कैसे हो रहा है?
जी, अब नेक्स्ट स्लाइड पे हम इसको डिस्कस करने जा रहे हैं आगे आगे, अभी बता रहा हूँ। सो गोइंग टू of two alpha globin chains, two beta globin chains, and with each alpha and globin and beta globin chain, iron is attached, which is called the heme group. So hemoglobin, globin is alpha and beta globin, and heme is the iron which is attached. So any pathology of heme will leads to a congenital inherited condition called sideroblastic anemia. Sideroblastic anemia can be congenital or acquired. And any pathology of alpha or beta thalassemia will leads to alpha or beta globin chain will leads to thalassemia, which is called alpha thalassemia or beta thalassemia. So an acute onset anemia or chronic. If patient is hemodynamically stable, heart rate is normal, blood pressure is normal, respiration is normal, it is chronic anemia. And the patient is stable. If heart rate is very fast, patient is in shock, patient is sick, so most likely I'm dealing with a sudden onset of conditions like G6PD deficiency may present to me with sudden onset of anemia when patient is exposed to a drug or to a food which is associated with red cell lysis, hypoxia, may lead to sudden hemolysis, may lead to sudden presentation of shock. So if patient presented to me with a sudden onset of anemia, sudden shock, I may transfuse the patient on even hemoglobin of even 7 or 8 gram. But if patient is chronic anemia, no heart, no tachycardia, no respiratory distress, blood pressure is stable, patient is doing normal routine work. I'm not going to transfuse the patient. So this is a HIND clinical, which is important. You people have to know. If it is an anemic patient, I will do is examination of the patient. Is there lymphadenopathy, hepatosplenomegaly, breathlessness, tachycardia, or bleeding or occurred blood loss, GI blood loss, or apparently any blood loss. So clinical examination is important. So the question which one of the doctor just asked, I'm going to go towards that question, but I will repeat here that the first test after anemia, which I will perform after seeing the anemia, is retic count. A retic count normally should be between 1 to 2%. A retic count of less than 1% will increase suspicion of bone marrow failure to produce hemoglobin, red cells, and a retic count of more than 2% is shows that red cells are hemolyzing, red cells are breaking after coming out in circulation. So these are the reticulocyte counts seen, which you can see on microscope. So these are the normal values. Now coming to your point, two important things which I want you people take home lesson of the day. The number one is RBC count. RBC count are usually normally 4 to 6 million. And the second take home is RDW should be less than 15, the last one. What I used to say that the most common test which any doctor perform in the world is CBC. And the same time, we do not know what is the meaning of RDW, and we do not mean that what is the significance of RBC count. Therefore, my approach and the reason of today's lecture, the reason of today's talk is to understand the basics of CBC, which are going to help you throughout your life career. So, to take home most important thing count, as I told you, that normal mean corpuscular volume MCV should be 80 to 100. If less than 80, we are dealing with microcytic anemia. If more than 100, we are dealing with macrocytic anemia. More than 11 in women is anemia. So anemia is there, MCV is less, is microcytic anemia. Anemia is there, MCV is more than 100, macrocytic anemia. Anemia is there, MCV is between 80 to 100, is normocytic anemia. And then the second test is RBC count and RDW. RBC count, usually the normal value is 4 to 6 million. We have a formula of that RBC count multiplied by 3 should be equal to hemoglobin. If someone is having RBC count of 4, his hemoglobin should be 12. Okay? A is RBC count multiplied by 3 is equal to hemoglobin. If this B
Sir, please repeat
multiplied
from
by
the previous
hematocrit,
slide. Your voice was breaking.
if hemoglobin is multiplied by 3, it should be the hematocrit. So this
Excuse
is
me,
the
sir. Your voice is lagging. Can you please repeat it?
yes.
Please repeat from the previous slide, sir.
You want to see the previous slide.
Yes.
This one.
The calculations on the next slide after it.
No, I have shared with you this slide, and then this is the one which I'm seeing.
All right, sir. Please continue.
Shared with you. So this is the rule of 3. If hemoglobin is divided, just remember this. Hemoglobin divided by 3 should be equal to RBC count. In this case, a hemoglobin of 15 divided by 3 should equal to 5. Hemoglobin divided by 3 should equal to RBC count. We will discuss this in detail in next slides, okay? These are the normal values. So microcytic anemia, normocytic anemia, macrocytic anemia, we have already discussed it. RDW should be less than 15. It's written 13, but you can take it more, like less than 15 should be normal red cell distribution width. So now come to the point. This is a normal CBC, hemoglobin of 16.2. The WBC on the top is 6.8 and platelet on the bottom is 179. MCV is 88. RDW is 12.5. So this is a completely normal CBC. Okay, 16 is hemoglobin, WBC normal, platelet normal, RDW normal, MCV normal. The fourth test which I want to see in my CBC interpretation and anemia workup is the peripheral blood. That what type of cells are present in the slide. If you are lucky enough to receive a CBC report in your hand from a better laboratory where a good hematologist have shown the reasons, that what type of the platelets, what type of the white cells and what type of the red cells, then you will find out that CBC tells you a lot. Like size of the red blood cells, as small red blood cells, large oval macrocyte cells. Large oval macrocyte red cells is characteristics of macrocytic B12 folate deficiency anemia and hypersegmented neutrophils. If these two words you can find out in your peripheral blood CBC finding in the comments of the morphologist that this patient is anemic, hemoglobin is 8, RBC count are normal, but MCV is high and oval macrocyte seen with hypersegmented neutrophils. I can put my money, I can bet it on it that I'm dealing with B12 and folate deficiency, I'm dealing with megaloblastic anemia, and that is the way forward. But if a patient morphology said that is hypochromic, microcytic, red cells are small, size are small, and elliptocytes, then I will feel that I'm dealing with iron deficiency anemia. So morphology is very important. A 25 years old woman having 22 weeks pregnancy come in OPD with chief complaint of low hemoglobin, weakness and vertigo. Hemoglobin is 6.2, MCV 59, TLC normal, platelet high, platelet 6 to 3, white cells is WBC is total leukocyte count is 8.2. RDW is 20. Normal RDW is less than 15. Here RDW is 20. So any volunteer, what we are dealing with, hemoglobin 6, MCV 59, RDW more than 20. So two most common causes of microcytic anemia are
Iron deficiency anemia, sir.
very good, very good. So now what I'm going to discuss with you, that how can you differentiate between iron deficiency anemia and thalassemia minor. So what I told you, they are the two most common causes of microcytic anemia. When MCV is less than 80, they are the two most common causes. One is iron deficiency, the second is thalassemia minor. How can you differentiate between iron deficiency anemia and thalassemia minor on the basis of CBC report? If RDW is high, it is iron deficiency. Normal RDW, red cell distribution width, is less than 15. If red cell distribution width is more than 15, you should, and you are dealing with microcytic anemia. Question 1, anemia. The point 1, the patient is anemic, 6 hemoglobin, MCV 59, and RDW 20. You are dealing with iron deficiency anemia. Okay. Whereas, now come to the point, if RBC count is more than which is expected, if RBC count is high, your suspicion will be for thalassemia minor. For example, in this case, hemoglobin is 6 divided by 3, RBC count is 2, and the RBC count in this report is 2. So RBC count is either low, or as per the hemoglobin, there is less likely chances of thalassemia minor. I will not put my money on thalassemia minor. I will bet on this patient for iron deficiency anemia. Is it clear?
I've not yet understood about the RBC.
What's your query?
Sir, can you
Can you
repeat
clarify
the?
how to
I'm repeating
confirm the
it. Okay,
thalassemia
listen.
minor?
You are dealing with microcytic anemia. Okay,
That
listen.
one.
What I said that the most common cause of anemia is microcytic anemia, and two most common causes of microcytic anemia is iron deficiency anemia and thalassemia minor. Now, what I'm telling you, in iron deficiency anemia, there's high RDW, and in thalassemia minor, there's high RBC count. If in CBC you find out RBC count are normal, but RDW is high, this is a case of iron deficiency anemia. But if you find out that RDW is normal, less than 15, and RBC count are high with microcytic anemia, then we are dealing with thalassemia minor. That is the point.
Okay, understood. Thank you.
Good. So these are the iron deficiency anemia cells. As per morphologist point of view, very different. I'm going to talk with a very different thing with you people. If someone is interested in morphology and microscopy and pathology of the laboratory, if you sit in the microscope and see the iron deficiency anemia slide, you will see like this. The red cells are empty, they do not have hemoglobin, so hypochromic, and their size is smaller than a small lymphocyte size. So the cell which is on the 6 o'clock position in this diagram, which is on the 6 o'clock position, is a standard small lymphocyte. And any red cell which is smaller than this small lymphocyte is microcytic red cells. Just to discuss with you how it looks like in morphology and how a morphologist saw this on microscope, and how you without going in any other detailed investigations, simply by seeing these morphology in microscope, you can differentiate between hypochromic, microcytic, iron deficiency anemia slides. A red cell of small in size and there is no chromium, means no hemoglobin, is microcytic and hypochromic. So these are the laboratory investigations we performed usually as a standard of practice to identify a patient with iron deficiency anemia. Usually we perform three tests, that is serum ferritin, total iron binding capacity, and serum iron. So serum ferritin of 33 to 270 is normal. Total iron binding capacity TIBC of 300 to 340 is normal, and serum iron of 50 to 150 is normal. So serum iron of less than 50 or ferritin of less than 33 or total iron binding capacity of more than 350, like more than 400, showed iron deficiency anemia. The point which you people should understand here, that total iron binding capacity of more than 350 shows these are the proteins to which iron binds and travel in the blood. When there is no iron, these proteins are free and they show a high number, high count. So that is the point which you should understand. A high total iron binding capacity means there are more empty rickshaw, there are more empty taxis where iron can sit and move. But if this TIBC, total iron binding capacity, is low, this is against the iron deficiency. So when the capacity to bind iron is more, it means they do not have iron. They have the empty seats. They have the seats that are available where iron should seat, but because there is no iron, the more seats are empty. Like more than 400 seats are empty. You got it? So these are the investigations for iron deficiency anemia. How you differentiate? Just focus on two things: iron deficiency anemia and thalassemia. Don't confuse with sideroblastic lead poisoning, chronic infection, hemoglobinopathy. Just two things. The number one is iron deficiency anemia and then thalassemia. In iron deficiency anemia, iron is low and TIBC is high. As I told you, the empty seats are high. Okay? Whereas in thalassemia, you are seeing a patient with anemia and microcytic anemia, but iron is high and TIBC is normal. So this will differentiate you between iron deficiency anemia and thalassemia minor. 28 years old female having 26 weeks pregnancy come in OPD with dyspnea and exertion. Hemoglobin is 5.9. The patient is 5 years old. and platelet count is 357. So I am dealing with anemia with hemoglobin of 6, white cell normal, platelet normal. MCV is low. So I'm dealing with microcytic anemia. Okay, RDW is 15. So RDW is not high. So it's just borderline high, not very high. It's on the maximum. But if you divide 6 with 3, the RBC count should be 2. But in this case, RBC count are 5. So microcytic anemia with high RBC count. What is your diagnosis?
Thalassemia
Thalassemia
minor.
minor.
Excellent. So my the result of my efforts. That was my take-home message. If microcytic anemia with high RBC count, you are dealing with thalassemia. Microcytic anemia with high RDW, you are dealing with iron deficiency anemia. And there's a history of first baby, normal vaginal delivery, no history of blood loss, a 7 to 8 gram, and she was transfused 2 packed cells in previous pregnancy, and she gave birth to a thalassemia major child. So if this CBC was interpreted by a genius doctor like you, they must have identified on the basis of CBC, excuse me, hold down. Am I dealing with a thalassemia minor? Hello, wait a minute. Just go and check your electrophoresis and please get electrophoresis of your husband done as well. If your husband is not carrying thalassemia minor, even you are carrying, your baby is not going to be having the thalassemia major. But if your husband is also carrying thalassemia minor, you are carrying thalassemia minor, there is 25% chance as per autosomal recessive inheritance your coming baby may be thalassemia major, and as per the Islamic Sharia and as per the Islamic laws, you can abort your baby before 16 week of pregnancy. If it was 16 weeks in the previous pregnancy, you can identify. So I always used to say that if you have a baseline CBC at the time of booking of a woman, and if she is showing microcytic anemia with RBC count high, please screen her husband. And if husband is thalassemia minor, there's a high suspicion this lady is also thalassemia minor. You can go for coordinated blood sampling. That is the fetus of thalassemia major, and if fetus is thalassemia major, you can abort the baby before 16 weeks. So this is the algorithm, which is Ansari and Shamsi algorithm. Me and my teacher have proposed it, that if a women came at the time of booking, perform CBC. If microcytic anemia, check the husband CBC as well. If husband is again microcytic anemia and high RBC count, perform electrophoresis of husband and wife. If husband and wife both are minor, please perform coordinating weeks of gestation, so you can abort the thalassemia child. So this is a guideline trial of oral iron should be considered wherein increment demonstrated at 2 week is a positive result. So what is said in Canada, in anemia, not anemia, microcytic anemia. And if she is, you should offer an iron trial of 2 weeks. And if showed increase in hemoglobin, then it is the iron deficiency anemia. NHS England. So what the Britishers do is they have a natural solution of just offering the treatment and management instead of doing a very expensive and extensive test which no one can afford. A point like you are doing the serum iron, ferritin, DIBC, or if the or if electrophoresis to find out the thalassemia. This is a case when hemoglobin is 7.5, MCV is 60, and count is 2.7. Female referred by GP for pancytopenia, thin, slim on examination, anemia, no organomegaly, dyspnea is there, and weakness is there. Hemoglobin is 6, MCV is 110, MCH is 34, RDW 10. So, what is your differential diagnosis and what type of cells you can appreciate in this blood film? Any volunteer?
Hypersegmented neutrophils.
Excellent. And MCV is high. So, macrocytic anemia?
Macrocytic megaloblastic anemia.
Yeah. What are the most common causes of macrocytic anemia?
Folate and
B12 and
B12
folate deficiency.
deficiency.
What are the most common causes of macrocytic anemia, MCV more than 100?
B12 and folate deficiency.
Excellent. Very good. So, so this is a typical morphology in red cell: oval macrocytes and hypersegmented neutrophils with RBC with MCV of more than 110 and anemia. And you should always remember one thing: cause of pancytopenia like hemoglobin less, white cell less, and platelet less than normal is B12 and folate deficiency. Patient with B12 and folate deficiency quite often present with pancytopenia like red cells, white cells, and platelets. All three lines are shut down. You got it?
Yes, sir.
So the most common cause of macrocytic anemia is B2. The most common cause of macrocytic anemia is B12 and folate deficiency, and this is called megaloblastic anemia. Whereas the non-megaloblastic causes, the other causes of macrocytosis and anemia are liver disease, hemoglobinopathies, metabolic disorders like hypothyroidism, myeloid dysplastic syndrome, any cause associated with high red cell destruction, or drugs like azacitidine, immunosuppressants like hydroxyurea, mycophenolate mofetil, anticonvulsants. If a patient presented to you with he has a lifelong history of taking anticonvulsants and macrocytic anemia, you should consider this drug may be the culprit and this may be associated with the problem. So again, a test case: hemoglobin of 10, which is anemia, MCV of 117. So you're dealing with macrocytic anemia. These are the oval macrocytes and hypersegmented neutrophils. So friendship with a good morphologist is going to save your life and your patient's life when you are so lucky to have B12 and folate deficiency. And these are there are some congenital inherited causes of megaloblastic. I have a case, I've reported a case where there was a congenital deficiency of transcobalamin 2. One of the she wrote a paper with me, and that was the transcobalamin. She was a student of fourth year when she wrote this paper, and that was the case report that congenital inherited transcobalamin 2 deficiency admissions, infections, and once we treated the patient with B12, multiple doses of the food sources which are rich. Iron is rich in meat and green vegetables and dates, whereas B12 and folate is in the liver, kidney, egg, cheese. These are the food which contain dairy products. These are the average input of requirement of folate and B12. So the reason why B12 and folate is associated with pancytopenia is one of the reasons. It's the with the nuclear deficiency of this will leads to B12 and folate leads to immature red cells and hypersegmented neutrophils and severe anemia and pancytopenia. Bleeding from ear and nose 2 weeks, bruises all over the body 2 weeks, hemoglobin of 6, TLC of 1, and platelet of 30. MCV is 95. MCV is on the high side. And then a 55 years old rickshaw driver referred by general physician with pancytopenia, habitual of intake pan and gutka, anemia positive, no viscomegaly, and MC hemoglobin of 6, white cell of 2, platelet of 50, MCV of 110. So you are dealing with macrocytic anemia secondary to B12 and folate deficiency. 20 years old girl, weight only 30 kg, weakness for 2 months, lethargy, dietary history under, she's not good in eating and normal cycles, no GI blood loss, hemoglobin of 6.9, again energy nervosum, and 18 years old male coming OPD with loose stools for 10 years, intolerance to wheat and wheat containing products, gum bleed once a year, endoscopy showed patchy shorting of villi in the duodenum. So you are dealing with celiac disease, and this is a hemogram. RDW is 16.8, and white cell are low, platelet are low, MCV is high, 106. So again, B12 and folate deficiency. So these are the basic lessons which I want to deliver you people today. Interpretation of CBC. Initially, you have to see the hemoglobin, white cell, and platelet. If hemoglobin is anemia is only low, you will start workup for the anemia. My presentation was more focused on CBC interpretation and workup of anemia. If anemia is associated with high retic count, you are dealing with hemolytic anemia. If anemia is associated with low retic count, hypoproduction. If this is hypoproduction, more common causes of hypoproduction anemia is less B12 and folate or deficiency of iron. Whereas if there's high retic count more than 2%, you are dealing with either immune hemolytic anemia or non-immune hemolytic anemia. If there's immune hemolytic anemia, the cause is autoimmune disorders like ANA profile, and you will check all those things. But if this is non-immune hemolytic anemia and the child, the patient is a pediatric age group, you will go for the inherited congenital causes like thalassemia, red hemoglobinopathy, red cell membrane disorders like hereditary spherocytosis, red cell enzyme disorders like G6PD, pyruvate kinase. And if there is no congenital inherited cause like membrane, enzyme, or hemoglobinopathy, you will check the patient for infection, fever, malaria, microangiopathic hemolytic anemia. And if you have to find out one of these things which may be responsible for the anemia. But if at the same time patient is having low hemoglobin, patient is having low hemoglobin with low white cells and platelet, the most common cause is megaloblastic anemia, and then you will find you will work up for B12 and folate deficiency or any history of drug in the family. The patient is on drug like immunosuppressant or anticonvulsants. And then the most important message of the day: for identifying a microcytic anemia. The two most common causes are iron deficiency anemia and thalassemia minor. In iron deficiency anemia, RDW is high, and in thalassemia, red cell blood count is high. Yes, I'm open for any question from my and the presentation is end. And now it's your turn. Any questions, any queries?
Sir, actually, I've had a question that was frequently asked in the forms as well. वो ये था कि what are the common mistakes that we as medical students can make while interpreting CBC?
Yes, what I try by myself to mention here that two, three important things. The most important, you cannot take CBC without the clinical history and examination. The most important. Just stick with your clinical examination and history. Only CBC is going to help you something, but at the same time, if someone is having lymphadenopathy, if someone is having hepatosplenomegaly by the age of 30, 40 years, high grade fever, my top differential will be leukemia or lymphoma. Whereas a child with a 6 months age, hepatosplenomegaly, anemia, my top differential will be thalassemia. Whereas a child with a man, a boy of 22 years of age, a girl 22 years of age, only anemia, no hepatosplenomegaly, no lymphadenopathy, my top differential will be nutritional anemia. So I should know the age of the patient, sex of the patient, clinical examination of the patient before giving a straight diagnosis. Second, never give a direct statement, this is that. You should say, you know what, my differential will be one, iron deficiency anemia, second, thalassemia minor, third, nutritional mixed deficiency, fourth, any other inherited congenital disorder. Always say like this. Don't just stick on one diagnosis and just say like during your examination, to your examiner. Always say, you know, sir, before giving response to this CBC, ideally I should have the history of the patient, the age of the patient, the clinical examination of the patient. Uh, Examiner want to listen this from you. That are you asking the age of the patient or the clinical examination? If you just explain him that I need all these things, he will start telling you, okay, this is a 6 months old boy with hepatosplenomegaly. Okay, sir, because hemoglobin is just 5, white cell platelet as normal, hepatosplenomegaly, either this is hemoglobinopathy or red cell membrane disorders. Okay, examiner said no, she's a girl with 22 years old and no hepatosplenomegaly, no lymphadenopathy. She's working normal. She's going to Paramedical College, third year MBBS. Okay, my most in my feeling, because there's no hepatosplenomegaly, no lymphadenopathy, no fever, no hospital admission, it's more likely benign condition like nutritional deficiency, boss. Sir, are you agree with me? Okay, he's an old age person, 50 years old, or old age patient like 65 years old. He have received 10 blood transfusions, not responding to iron therapy. Iron was normal, and no hepatosplenomegaly. So, and no platelets and white cell are normal. So maybe I'm dealing with myeloid dysplastic syndrome. So you should know the age, some history and examination. One point which I want to emphasize here, please, I'm just हाथ जोड़ के आपसे request कर रहा हूँ. Whenever you find out anemia, please check with hemoglobin, check with platelets. A combination of anemia and thrombocytopenia is a danger sign. If someone is having anemia with thrombocytopenia, there should be the bell should be ringing in your mind. I am dealing with malaria, thrombocytopenia with anemia, TTP, thrombotic thrombocytopenic purpura, DIC, sepsis, in pregnancy, HELP syndrome, in pregnancy, eclampsia, preeclampsia. So there are so many complicated conditions associated with anemia and thrombocytopenia. So whenever you check the CBC and if patient is having only anemia, then things are different. But if someone is having along with anemia, thrombocytopenia, a condition called thrombotic thrombocytopenic purpura. This is acquired and inherited both. It may be I have a patient today. I have a patient. It is congenital inherited TTP. He's just 1 year old. and he have congenital deficiency of ADAMTS13, which chop off the von Willebrand factor antigen, and it prevent the thrombosis, repeated consumption, coagulopathy, and thrombosis and platelet consumption. But in congenital inherited, I was trying not to make the discussion very complicated, but I want to clear it. But in TTP, these von Willebrand factors are coming out of the endothelial membrane, and platelets are stuck on this. The chop off enzyme ADAMTS13 is deficient, is not there. So the patient will start having fits like convulsions because of microangiopathic conditions in the brain or kidney failure. So any patient like TTP, if you do the plasmapheresis within 24 hours, there's a 90% chance of saving the life. And if you do not do the plasmapheresis in 48 hours, there's 90% mortality. So it is just like if you miss a ST elevation on ECG and you did not pick it up, and patient will die in MI. The same way, if you saw CBC, it was written there, microangiopathic anemia, red cell schistocytes are there, fragmented red cells are there, anemia and thrombocytopenia, and you did not refer, you did not pick TTP, you did not refer the patient for plasmapheresis, patient may die and you will be guilt forever. So please take every patient with anemia and thrombocytopenia serious. And the most common cause of anemia and thrombocytopenia is malaria. Okay?
Sir, sir, how can we differentiate between malaria and dengue as in both cases we have thrombocytopenia? Like how can we differentiate on the basis of CBC?
I love this question. Medical officer called me at 1 o'clock in the night, sir. We have a patient with hemoglobin of 16 and platelet of 50,000 and white cells of 5,000 or 4,000. Okay, yeah, it looks like a dengue, just treat like dengue. And again, receive a call, sir. We have a patient with hemoglobin of 14, platelet of 30,000, white cells of 4,000. Okay, looks like dengue, check dengue and treat like. Then receive a call at 4 o'clock in the night. Sir, we have a patient with hemoglobin of 6, platelet of 30,000 and white cells of 4,000. Excuse me, hello, hold on. Why hemoglobin is 6? Dengue usually present with false high hemoglobin because there's a shift of fluids from the intravascular space through endothelial leakage. It's a capillary leakage syndrome. So the red cells concentration will be high in the vessels and the CBC will show a falsely high hemoglobin. Dengue do not present with anemia, whereas malaria present with anemia and thrombocytopenia. Dengue present with no anemia, thrombocytopenia, and maybe low white cell count. Does it make sense?
Yes, sir. Thank you so much.
Sure. This is again an interesting point, how to differentiate between malaria, dengue on the basis of CBC. So what this genius doctor just asked me, yes, I agree with her that on the basis of CBC, a high hemoglobin, falsely high hemoglobin and low platelet is dengue, and low hemoglobin and low platelet is malaria. And in typhoid, in enteric fever, we usually have low white cell count, normal hemoglobin, and platelet may be normal or may be low. Platelets are not high, but white cells are on the lower side, like neutrophils are around 1,000 or 1,500. Okay?
Anybody has any more questions, or should we just wrap up?
Sir, what would the CBC report of a thalassemia major patient look like?
Thalassemia major patients usually they are isolated anemia. No, simply isolated anemia. They usually present within first year of the life. Most of the time within the 6 months of the life, by the age of 6 months. But they may present later by the 1 year of age, and that is an isolated anemia. But you cannot differentiate. Mostly it's microcytic anemia, but not necessarily microcytic anemia. But 90% of the patient is having hepatosplenomegaly. So any patient with microcytic anemia, I usually send both laboratory investigation at the same time I send the iron profile and electrophoresis. Even I'm very much sure that I'm dealing with iron deficiency anemia. Still, I send the electrophoresis because if once he's transfused, you cannot perform hemoglobin electrophoresis. And in electrophoresis, the hemoglobin F of more than 50% or 80% is diagnostic of thalassemia after the age of 6 months.
Sir, do
Okay,
we
doctors?
usually take sir, I have one question that do we usually take radiographs of thalassemia major patients to look for skull deformities due to extramedullary
No,
hematopoiesis?
never, 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 never. Just anemia and electrophoresis is enough. Always
Okay.
try to get electrophoresis of an anemic child. Please, please, please. If you are living like my teacher, Dr. Khalid Saab, and NSCH used to say me that all Pakistanis have tuberculosis until proven otherwise. The same way, any anemic children may have thalassemia. Please, by performing a test which costs you 1,000 or 2,000 rupees, for the lifelong, the patient will be on the blood, and every laboratory will say, sorry, we cannot perform electrophoresis. You are already on blood transfusion. The only investigation which we can do at that time is genetic testing for thalassemia. So instead of complicating the situation, any pediatric age group patient less than 1 year of age presented to you with a microcytic anemia, severe anemia, less than 8 gram, less than 7 gram, perform hemoglobin electrophoresis. Even if you are not performing iron B12 folate, if you do not have the money to perform B12 iron, just offer the treatment. Just start iron B12 folate. But please perform electrophoresis. If it is iron deficiency, it will be cured with iron. But if it is electrophoresis is major, then you can always treat the patient like thalassemia major. Yes, please.
Okay, sir. Thank you very much. Now we are really grateful for Dr. Saqib Ansari for sharing his valuable insights and expertise with us today. We appreciate his time and look forward to applying the knowledge gained from this session. Now, let us formally conclude with today's webinar. Thank you, Dr. Saab, for giving us time from your extensively busy schedule. Thank you, everyone, for attending the session. Allah Hafiz. You may all
Allah
leave
Hafiz.
now.
Thank you. Thank you very much.